Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you chose to spend this time with us, and we are going to jump right into what I suspect is a very probing conversation this afternoon. And without further ado, I will turn it over to our founder, Dr. Randall Maxey.
Thank you, Dr. Barbara Davis Stevens. Hello, Dr. Walks and Dr. Hines. We are very excited to have a discussion today on something that's hitting all the buzz on the TV networks and newspapers. We're going to talk about medical AI. In fact, medical AI is a revolutionary healthcare diagnostic, treatment, and prediction event. AI enhances the accuracy in radiology, pathology, and surgical decision making. We explore AI's impact on preventative care, clinical workflow, and patient outcomes. This session will discuss practical uses and future implications of artificial intelligence in medicine. Our featured speaker is a good friend, Dr. A.J. Ananda. He's a board-certified neurosurgeon specializing in pediatric and adult neurosurgery. He's a former head of neurosurgery at Kaiser Sunset Medical Center in Los Angeles, and he's a principal in Dr. AI, which is the product we're going to discuss this morning. And I have met his father and mother by phone, and I'd like him just to briefly, as he comes, to give a quick introduction to them. And Dr. A.J. Ananda, appreciate you agreeing to speak with us today and entertain some of the questions we're going to put to you. Thank you.
Thanks, Dr. Maxey. I appreciate the opportunity to come on your program, and it's always nice to see you. I've been on here before years ago, and it's nice to be back. Hope I didn't wear out my welcome last time. Also, I'll introduce my father, who is really the head of the company I'm going to talk about called Hey Dre, and it is an artificial intelligence tool designed specifically to help patients, the individual medical consumer, on any issues with their health. And let me give you a little background in the just kind of like the idea behind it. So if you look back at one of the biggest changes over the last 30 years, just in American society, world society, human society, is the democratization of knowledge, right? So when I was a kid, we didn't have an encyclopedia, and people who had encyclopedias, you were kind of like jealous. You had to write a book report or report on anything, or if you wanted to find out anything as a kid growing up in the 70s and 80s, you either had to get to a library or find somebody, go to somebody's house or an encyclopedia, and you can get like a small blurb on, oh, okay, what does a chimpanzee look like? Or what does a toucan look like? What do they like to eat? But if you didn't have a certain window into whatever you're learning about, most of the world is foreign to you. And with the advent of the internet and the kind of popularity and widespread accessibility of smartphones, the whole history and abundance of all of human knowledge is essentially at your fingertips all the time. And so now, I grew up in a house where neither my mom or dad aren't handy at all, would never be able to change the light bulb, leave alone change the oil in a car or rebuild an engine. I have an old Mustang. If I want to like rebuild the engine, take out the clutch, install a new starter, all of these things I've done by myself with the most important tool being my phone, teaching me how to do it. And as such, over the last 20 years, as knowledge has become democratized, available to everyone, and for the most part freely, it has expanded a lot of things and a lot of opportunities for a lot of people. One area where this hasn't reached people to the same level it will over the next 10 years is in the form of healthcare. So if you are sick or your loved one is sick, you're often at the will or mercy of your access to a doctor. And if you don't have people in your family or close friend group that are other physicians, it's very hard to vet the good from the bad, Can you even get an appointment? Can you get an appointment with the right physician? Have you had the right test? What do the results of your tests mean? All these things can be very mysterious and often frightening and intimidating. The value of the product we're going to talk about, Dr. AI, is the ability, just like now you have the entire Library of Congress and the history of human film or whatever, all music on your phone, you can have a doctor in your pocket ready to talk to you about whatever question you have at any time. 24/7. So just like you can, in the middle of the night, Google, oh, I want to see a samurai movie on YouTube, and you can certainly find one. But if you had an earache, or if you recently got diagnosed with a weird blood disorder and you got the lab test back and you don't know what this means, are you safe? Are you not safe? Dr. AI is a interactive artificial intelligence that you can type in questions. It'll ask you for very pertinent information that'll help get you to whatever specific answers you're trying to get to in the most efficient way. So that's just a quick, Reader Digest, or, if you're my age, Carol Burnett version of the story. Probably what would be easiest is, ask me questions and I'll try to answer them.
Okay. So prior to the program, we are talking about the sources that the AI process uses to get us information. And we emphasize on this program that we use vetted, well-respected physicians who've published and written, and we respect them and their information. So how would Ms. Jones from First Baptist Church get a good answer and knows it's reasonably good from Dr. AI?
Yeah, so let's talk about it operationally. So the way this works, this is a website, and you can go for free, Heydray, HEYDRAI.ai, Heydray, and all it costs is you putting in your email, sign up for it. And once you sign up, it'll start a conversation as if you're having a conversation with your doctor. And it's not open Monday through Friday, 8 to 5, but it's a program, it's a machine, and you can start this dialogue with it. And once you introduce yourself to it and whatever the Mrs. Jones problem, you may say, I have abdominal pain, I have a tummy ache. And then it'll ask, okay, what's your age? It'll ask questions specifically, about the problem you're having. And it'll guide you to whatever information you may have had, whether you've had any blood tests, x-rays, ultrasounds, and it'll give you easy ways for you to either input your information, upload your information, whatever is easiest for what the information you have. And then it'll give you specific, a differential diagnosis, next steps, treatments, all tailored to the information you've given it. Now, then you can ask, Dr. Maxey, that's a very good question. How does Ms. Jones or any other user trust this information? Well, the nice thing is it's going to give you an answer. And if you've ever worked with any other, search engine, you can ask more detailed questions, specifically asking, what are the sources of this information? So you can trace it back to its original source. That's one option. The other way is that this is not supposed to be in lieu of having, seeking an actual doctor. This is to provide you some background material and to help you when you see a doctor, you can have a more informed consent, a more informed discussion of what things it might be. Or you may even have to remind, what you can ask your doctor, well, what about this? What about that? Can I have this test? Can I have that test? And what people will find, I used the analogy before, if somebody tells you, oh, the sky is green today, well, it's easy enough to test. You walk outside, you look up, and you can see the sky is blue. For something that the knowledge is a little bit more restricted, so if they say, well, your ejection fraction is a measure of your heart function, and you have a test that says it's 28%, and you want to know, is this healthy for my age? Is this unhealthy? What foods I should do? Are there exercises I should avoid? Medications I should avoid? that is something that, you know, finding on your own may be very difficult, but using a virtual doctor where you can ask questions repeatedly, you can ask where the answers are coming from, that's the real value. And so to make sure I'm hammering directly on the question that you asked, to believe the source, you may want to, so is this information coming from, you know, the National Institute of Health? Is it coming from Sports Illustrated? And so I think the key is, depending on how involved, how curious you are, you can kind of dissect that onion to try to get to the very bottom of it. Some people will take it on face value, and that's fine, and they'll believe it based on the way the answer is given in relation to other answers or other questions that you're involved with. Other times you can be very direct and say, well, how do I know this? How do I know that? And you can, and if you're satisfied with the answer, great. Otherwise, it can direct you to, just like when you read a scientific paper, often at the end there are footnotes as to what resources the paper is built upon. And similarly, you can keep asking questions to get to the source material.
Well, thank you. That's Neighbor Stevens.
Well, I'm going to go ahead and ask a question because it's an excellent question in chat. Uh, one of the audience members wants to know, how does this differ from Perplexity AI and Chat GPT? Is this an app?
So both great questions. Currently, it's just a web-based program. Within the next 3 to 8 months, we'll have an app. So that's the second answer first. It's not yet an app. It's a web-based program that you can use on your phone. You can do it from a laptop, a regular computer, or your phone, but it doesn't sit on your phone architecture like an app yet. That will be coming soon. That's the next iteration. And how it differs from ChatGPT is ChatGPT, one, has a more narrow database from which it's searching from. That's on the production end. On the input end, with ChatGPT, you know, I use ChatGPT a lot for planning trips, or, you know, looking at nowadays solving math problems for my kids, or, you know, for a variety of things, like places to go, restaurants to eat at. But however effective ChatGPT is, it's really based on the questions you ask. So for a non-sophisticated medical person, the advantage of Dr. AI is it will ask you questions as if you're talking to a physician. So if you say, like, my stomach hurts, it'll ask, okay, what did you eat? How long has it been going? It'll ask you the questions by which to get the information so it can most narrow down and optimize the data it's searching from. That's why it's going to give you the most optimal answer. It's going to make sure that you give it the information that's most germane to the problem you have. And that's the architecture of the program itself. So one, it will be able to narrow its own search. And so that's one difference in ChatGPT. And the other difference, it has a broader set of information it's searching from.
Thank you. That's Ivan Walks.
So let me give my disclaimer first. Every time I hear AI, I have horrible flashbacks to all the Terminator movies, and I saw the recent Mission Impossible movie. It always ends badly for the humans, right? No matter how it starts. So I am beginning, though, to try to act like I'm not an old person and just connect with the whole concept that AI is something that is here and is helpful. My question, though, is, Dr. Maxey started by saying how the information that we give on Black Health Trust is vetted information from folks who have, published and what have you. When Dr. AI is looking for the answers, is it only looking in places, because we're getting a lot of different medical information now. Vaccines are good, they're bad. The COVID vaccines are good, they're bad. I mean, everything is good and it's bad at the same time. So the question would be, how do we know, or do you know, or is there a way to look and see, where is Dr. AI getting the information, and how are the algorithms in that particular process vetted and built on real solid stuff? That's a very long question, but you understand what I'm asking.
100%. And so I'm going to answer in 3 parts, because there's really 3 questions in one. first question is, it's a philosophical one. Is AI going to hurt us or help us in the long run, right? Like the Mission Impossible Terminator scenario. And the question and the answer is, one way to find out, we don't know, right? We don't know, because right now, in all those movies, Terminator, Mission Impossible, the AI has become what's called AGI. It has a conscious and desire on of its own, and the motives of this new entity, the AI entity, aren't necessarily aligned with the desires and motives of humans. Where so we can just say we can kind of like blank all of humanity into a single desire. Is like we want to persevere. We want our kids to have a life. We want our grandchildren to have a life, and so on and so forth. That's our kind of like, if you take that as humanity's goals, that may not be aligned with the next kind of like super conscious AI. So the good news is we don't have a super conscious AI yet, but that's a really good question, and I'm not really sure humanity has the answer. And when you find out, it may be too late. So that's a real existential threat of AI. That's a different AI than the one we're talking about. The one we're talking about is merely a tool. It won't have any motives or anything like that. It's only raison for existence is that as a way of consolidating information. All right. And it has two mechanisms that are really unique to the Hey Dre that do it. One is how it pulls information from the consumer so that it can more narrow down the substructure of data it's trying to get. And the other is how it searches. Like if you look at the entire tome of digital information, so that's PubMed and all, all of the Google searches and ChatGPT, the OpenAI data structure. And so that's the second question is, okay, how does it actually benefit? Because there are so many things in modern medicine that are controversial, right? Who should get a COVID vaccine? When is it safe to get a flu shot? When is it, so these are all, these all can fall under the subcategory of controversies of modern medicine. And so the truth is, if you ask like 10 virologists, you're really going to get two answers. I think 7 of them are going to say most people should get COVID vaccines. 3 will not, right? That's kind of that's the nature in so many things in modern medicine. And so this is not going to eliminate controversies. In times when the answer to a specific question, so in this case, I'm a 53-year-old guy who is relatively healthy. Should I get a COVID booster this coming fall? The answer will reflect the kind of the state. It'll say that the vast majority of people, given your age and your exposure risk, will suggest that. But it'll have a disclaimer: there are people that say it is unnecessary because your risk of real morbid disease is low. So, and that's the best answer one can give on this controversial subject. If you can say, yes, for sure, you need to get a COVID vaccine, that I wouldn't say that's a great answer. And if you say like, no, it's not right, that also wasn't a great answer. But based on the best knowledge that we have available, the answer would be this. And so for areas that are clearly controversial in medicine that are not completely fettered out, for example, if you have lung cancer, you shouldn't smoke. Or if you have emphysema, you shouldn't smoke. You shouldn't you should restrict going to humid places. These are relatively non-controversial subjects, right? I mean, heart failure and different inhalers. There's the right combination of medicines and there's the wrong combination of medicines. The vast majority of things that deal with specific treatments for illnesses, these are relatively acontroversial, and the data will bear that out. And I think it'll spell it out as such. But for the very inquisitive and say skeptical thinkers among us that don't want to have don't want to take just the answer at face value, you'll have plenty of that. The information is given to you in the form, it's texted. The next iteration will be via speech. That's probably 3 months away. But right now it can be in multiple languages also. But right now it's in English, and it's you text to chief complaint. It'll ask you a question, and it'll be a dialogue like that. you can ask further follow-up questions, all like I say, tracing all the way back to the source. And when it's a subject that's somewhat like when I graduated med school in 1997, the use of beta blockers in heart failure were relatively controversial. There are people that say yes, people say no. Now that controversy is more or less squared away. So this changes from year to year, even sometimes month to month. And so that's another difference between this and ChatGPT. ChatGPT that exists on a data structure that was updated, I think, last in October of 2022, whereas this is live. It's always being updated because it searches PubMed, ChatGPT, and then the greater like internet also. And since I'm not in the programming space, I'm not sure the algorithm by which it prioritizes Lancet this much, NEJM this much, a small cohort study. So I think that's a very good question. I think the next iteration, and for the professional product, which we don't have out yet for physicians, that'll be part of it, is like displaying in full force. And we can open this up to the individual, just the lay people as well. The dials, how much we value one publication, one type of study, looking at p-values and perspective, what we call class 1 data versus class 2 data. But all that, when it comes to the layperson, is a little bit, even for me, who I don't do a lot of actuarial analysis, and I know a lot about neurosurgery, but not much about heart failure or liver function or renal disease. I'll take it on face value, and if there's a controversy in the subject, it should, like the COVID vaccine is a great one. There should be a disclosure, and I think that's very important. But for most treatments, for a very specific medical problem, most of medicine is protocol driven. If you have lymphoma at this stage, you're going to get this type of chemo regimen for this 3 months, and you have to worry about this type of side effects. And these foods make these side effects worse. These medications, makes these side effects better. So these are the kind of information that, if you have friends that are oncologists, or if you have access to a nurse that delivers that chemo, it's very easy when you or a loved one is going through that type of cancer treatment. But for the vast majority of people that don't have access to it, to get those answers in a conversational way is very, very, very valuable.
Well, thank you.
Thank you very much.
Dr. Hines.
So I have a bunch of questions, but I will try to hit my top two. The first one is around, you mentioned that you gave it a bunch of your information, right? You upload your lab results, your studies, blah, blah, blah. As we just saw with like the whole 20, as we just saw with like the whole, huh?
At your disclosure, you can give them nothing but your name if you like, but the more information you give them, it'll give you a more nuanced, detailed information.
No, understood. And so then the first question is around what happens with that information, right? Because where I was going with that question is, once we had that whole thing with 23andMe, right? You have some other entity has all your information, and then it's no longer in your control, right? So what happens with your personal information? The second question that I have is, while Dr. Walks gets visions of, Terminator when he thinks about AI, my concern with AI is that it, especially in the clinical space, it is trained on a system that created health inequity. So I'm concerned about the exponential amplification of those inequities, because the computer AI was developed by people, and the patterns that it's looking at also led to the situation that we have now. So how does Dr. AI kind of address or make corrections for, or do anything to address that?
Right. Two questions, and I'll answer the first one first. First question is, first of all, you're right. You are the person in control of your medical information, and that never changes. Even when you go to a doctor, if you go to Cedars is the custodian of your information, right? So they have your blood tests, they have your MRI reports, they have your doctor reports, and part of their electric medical record, and they're the custodians of that. But you really are the owners of that information. Meaning, whenever you want, you sign a thing and they give it to you. If you want to send it to me because you want my opinion as a physician, that's fine. There's a legal process by which to share that with another individual, another doctor's office, another hospital. And so this is no different. once you upload your information or whatever information you disclose to the program, there's a absolute, it's bound by the same laws of HIPAA as any other medical custodian relationship. So just like when you get an X-ray or you go to like an imaging thing on Ventura Boulevard for your head CT, they're bound by law that they keep track, right? Obviously they scanned you, they have a digital copy of that record, and then they send it to a radiologist. The radiologist reads it, and that radiologist has looked at your pictures, but they're all contractually by law obligated. They can't share that information with anyone without your approval. And just like the random imaging center on Ventura Boulevard, or the random hospital where your kids were born, so they saw your blood, they had to know their blood group and the blood type and whatever events happened when you had children. By law, you can have them share that information with anyone you choose, or you can share that information with anyone you choose, but they cannot without your explicit approval. And Dr. A is no difference. So there's no with 23andMe, I did that, my wife and I, but like, I don't remember the disclaimers, but there's no situation where with 23andMe, where like they're a doctor's office or anything like that. So maybe they are not bound by those same regulations, but with this, I can tell you with Dre, it is bound by the same HIPAA legislation and rules of medical information as if you go to see your gynecologist or your orthopedic surgeon. It's exactly the same. So there should be no difference there. So they can't share it without your explicit written wishes. They can't share it with anyone. Now, the second question about the inequities in health, that's I know I'm paraphrasing, but is that a fair description of it? So whenever you see an allopathic physician, right? You go to see the eye doctor, and so in the African American community, there's a higher rate of glaucoma than in the white community, and so a lot of times there's cataract disease, let's say, and when they look in the back of your eyes and they see, they do a fundoscopic exam, and they're looking at your retina and they see uncontrolled hypertension, for example, if that's what they see, or disease of atherosclerosis. If they, depending on their biases, they may or may not assume, this person looks like this, so they're going to have a certain level of hypertension that's not controlled, or hypercholesterolemia that's not controlled. They may or may not factor that into what's best for your vision, right? They may or may not. That's the concept of bias. That's the concept of inequity in healthcare, because the provider is making a snap judgment, either subconsciously or consciously, that takes into consideration something other than your health, right? That's the whole idea of when you talk about the inequities. At least that's the belief, right? That's the belief that, there's a study, I think it's been 10 years old now, but in the New England Journal of Medicine, that Black patients in America get different levels of pain control than white patients post-operatively. Okay, and that means something to me because I'm a surgeon. But that's not because of the system. That's because a surgeon, some provider who's doing the service, is making some decision biased, not on the surgery that he did or the patient or the problem with the patient is having, but on something else, on information that's not pertinent, right? Like their race, their gender, whatever. So the nice thing about an AI, it's dispassionate. It's not going to know that, okay, it's not going to think, okay, Black people have this problem, I'm going to treat them in this way. It's, to the AI, a Black person is as foreign or as alien to it as a white person, as an Asian person, as anything else, male, a female. For it, it's just another data. It's just another piece of data that it factors into it. So if you're white and you're 35 and never had a child and you're a woman, your rate of breast cancer is X, compared to if you are 30 and you've already had given birth to 2 children, your rate of breast cancer is Y. And so it knows that statistically just based on whatever the data says. But it would factor in, okay, this person is an unmarried woman, I'm going to treat this person differently because it doesn't have the bias. So I think your point is a very, very good one, that unfortunately in the modern delivery of medicine, of any type of healthcare or any type of customer service interaction, there is a bias. right? We want there not to be, but so many times there is. But when you're dealing with a computer program or with an with an algorithm that's essentially the only bias that would be put in there is that which is programmed in. And I can tell you from the people who are making Dr. AI, we're not programming a bias based on race or gender. The only bias is try to get the optimal solution for the medical problem. Now, the more layered question is, well, what about the studies out there? The science, is the science have an intrinsic bias. And that's something that we're only as good as the information that we can get, right? So if you say that, right now, like I said, I graduated med school about 30 years ago. In the last 30 years, people have become more cognizant to, okay, certain medicines, certain disease entities in different ethnic groups respond differently to different medication subtypes. ACE inhibitors for hypertension in Black populations versus Hispanic populations, for example. And that data we're still like early in collecting it. I mean, 30 years as opposed to 80 years in the more greater scheme of things. But as more information comes out, that's more germane to like treating the specific patient. I think, just as we, meaning allopathic medicine in general, are learning and becoming better, the information you get from Hey Dre or any AI, any informatics system will improve as the data improves. But you're always going to be limited by the data. There's no magic that I can think of beyond that.
Yeah, as our co-moderators look at the chat and see if there are any questions, I want to ask you a quick one. One of the things that we've been concerned about are the social determinants of health. Will this be programmed in it, as they have a lot of relevance to communities of color?
I'm sorry, say it one more time.
Social determinants of health have a weight on diseases, morbidity, and mortality. Is this being taken into consideration?
The short answer is yes, because we know that very much that your social background, right? Even something, how much money you have, how much education you have, how much social support you have. Are you married, unmarried? Do you have children in the house? All these things make a huge difference in outcome given any medical problem. Doesn't matter if it's cancer, back surgery, Parkinson's disease, dementia, name the disease. Recovering from COVID, all these things have a factor. And so whatever information, and so that's another beautiful illustration of how this is different from a ChatGPT or just a Google search. If you put a Google search is like, oh, I have renal cancer, what do I do next? As you said, your ethnicity matters, right? Your social background matters. Are you a smoker? What kind of foods you eat, your weight, all these things matter. And asking the questions to get that information is going to give the most nuanced and optimized information to answer whatever the question you have. So the short answer to your question is yes, and it's taken into account based on the questions it asks you, right? It only is taken into account if it looks for that information. And the system is designed to try to get as much pertinent information from the user.
Yeah, I told Dr. Walsh last week that he shouldn't eat barbecue, but Dr. Neighbor-Stephens, any questions in the chat that we need to address?
So I just wanted to circle back. I had mentioned about her first question was about the information being sold. I also want to the information was about the security of the information you give to a machine, right? And so I want to state not only is it HIPAA compliant, but the way the data is structured on the back end is stored compartmentally in such a way that even if there was like some weird outside person hacking the information, okay, our CTO just messaged me because again, I'm not in the source or I'm not in the programming business. So he wanted to give me a further illustration of the product's security. The information is divided and stratified in a way that even if one system was hacked, you wouldn't really find out any information because like your name and the data that's associated with it is like it's compartmentalized in a way. It's essentially impossible to share with any other entity without your explicit desire to do that, explicit consent to do that.
So there's a question there's several questions, but there's a question that asks, can this technology or should this, how would this, or how can this technology be integrated into an actual physician practice? And I actually was thinking about the converse of that. And what motivated me in thinking about the the converse of this is we are potentially looking at mass loss of access to healthcare in this country. And we have a significant part of our population that hops on Google and asks Dr. Google anything and everything. Anyway, so with access to this technology, let's say, I dial in and say, I got this rash on my cheeks that just had been there for 2 weeks. And every time I go outside, it seems to get worse. What do you think this might be? And the chat and the person have their exchange of information, at the end of which the chat hopefully will appropriately tell this person, well, you need to see a specific kind of doctor and have that appointment as soon as you can get it. However, the circumstances are we are in a society where that access may or may not exist. So the the positive question was, should the physician integrate this into their practice? And my negative opposite question is, how are we going to, what have you all thought about in terms of addressing issues of access as we progress in potentially a very chaotic period of time in terms of
Let
health
me add something
availability?
to your question. Could she upload a picture of that rash? Will it interpret that picture?
Absolutely, yes. So the answer to both those questions. So let's start with the first. Is could this be integrated instead of for the patient, for the provider, right? This would be a wonderful tool for a provider. And so, yeah, so when you really think about it, this product has four potential kind of like sides to it. There's a side for the lay individual, the consumer, a patient, right? And it's for on the side where it's for the consumer, for a regular lay person. It's to give information, things that, you come with a problem. These are the things that it could be. These are the tests that might be helpful. And it's to educate the patient on the problems, to make that person's next visit with their provider a lot more informational, right? It gives them a lot of background that they can talk to their provider about, and they have questions, and so that'll be a much more worthwhile interaction, having knowledge going into the interaction. So that's for the layperson. Or if the person doesn't have access to a provider and is really scared, just been given this news or just has this new symptom, they can get information that way. Then what you asked about for the provider itself. So as the population goes up and the number of med school graduates stays the same, and people actually, if you look at it, people are practicing medicine for shorter times. So now the functioning doctors, actually, there are studies that show the number of doctors that are actually physician work hours available to the American population at large are actually getting smaller. So we have to have this amplification of efficiency. So something like Dr. AI, where once it's integrated, where a patient can log on, send a picture to the site, describe their symptoms, and even before seeing the physician knows the picture, knows what labs that need to be ordered, has a differential. It can make that next interaction with the patient much faster, more efficient. It kind of essentially amplifies the efficiency for the physician. So that's the next iteration. Again, we're probably 3 to 6 months away to have a physician-based version of this. So I think that so the ultimate question you had is, one, can this be useful for a physician? Yes. And can this increase physician efficiency? Yes. And by improving physician efficiency, that's what's going to amplify access to people. Does that make sense? So I think the short answer is yes. We're at the relatively early stages. Even the website as it's now constructed for people to go on and play with and to use. It's just kind of like an enriched beta testing. So once we have it's like a soft launch. The next iteration, 3 to 6 months from now, will be both for the individual consumer and for physicians, where it can integrate seamlessly into their electronic medical record, where it will pull. Okay, Miss Jones has a rash. It can pull like, what's the most recent white count, SID rate? Are their diabetes under control? What's their cholesterol? Have they had this vaccinations? Do they have any risk factors for lupus? All the, are they allergic to any specific medicines, drugs, foods? So the next iteration is what it can, for the physician's office to seamlessly, or the patient to seamlessly integrate with your own electronic medical record. And so without you having to put information in, it can go back and forth, both input and take out information to make the diagnosis to most efficiently and accurately help with diagnosis, what's the next steps in treatment algorithms, treatment risks. It's the whole aspect of providing care.
Oh, thank you. Should we open the mics, Dr. Neighbor Stevens, Dr. Walks, Dr. Hines? Any questions?
While that's happening, I have another question. I was talking, first of all, thank you so much for all this information. Whether it scares me or not is not important. Because this is the way that we're going. I was having a conversation yesterday with neighbor down the street who is a very nice person, and said to me that what we really have to do is just stop looking at the differences in people, because what unites us is more than what divides us. The things we have in common are more, and so we shouldn't talk about race. Well, this is Black Health Trust, and so one of the challenges is that a lot of the science is different for different groups, and the incidences are different for different groups. And so as I think it's great that we can all hold hands together. At the same time, there are differences. And so as we talked last week about prostate cancer and about when to start getting screenings, and it's different for African Americans and other folks, and all of that is stuff that we know. As the science evolves, I know you talked about that a little bit ago, it may evolve differently for this group or that group, or for men or for women. And so I'm wondering, how do you anticipate Dr. AI staying current, being able to make sure the information I'm getting today isn't 2023 information, and that, you understand what I'm saying?
No, that's a great question. And so let me circle back to something that happened to me just yesterday. So yesterday I was helping a friend who lives in Florida, bought his parents who live here in LA a house. And he came for the weekend. He was helping them move in, and I was helping them kind of like get their house in order. Like, they had a bunch of furniture movers come in, and people building furniture and exercise equipment in the house. And my friend is like very tech savvy. He's a Chinese guy, and he's like, yeah, he has this like, Google, he plays with this Google Premium AI, where you can live talk to this, this make-believe woman. And so he gives me the phone. I'm walking around this house with this make-believe AI woman, asking him like, okay, where would a plant, what kind of plant would go here, and what picture would go here. And it's like this amazing interaction set, asking if am I looking for a minimalist aesthetic or a vibrant aesthetic, and it's like asking questions of try to like hone down. And then he's like, well, have him look at me and to ask him like questions about me, meaning the guy. And so I showed the picture, and he's a Chinese guy, born and raised in LA, is a Chinese guy. And I said, so what's this guy's ethnicity? And it says, oh no, we can't talk about that, because like the Google AI is programmed to like avoid subjects of race, ethnicity, any type of, it's very muted in things that it can do that touch on these kind of subjects. That's like it's like a hard stop for it, just as an example, because it's programmed that way. And you were asking about how obviously in America, there are actually a lot of different reasons for like if you look at, African Americans with prostate cancer, colon cancer, breast cancer, their survival rates are different from age-matched controls non-African American in America. And so there's a lot of that I think is to do with bias. A lot of that is to do with like, genetic differences or genetic comorbid differences, variety of epidemiologic reasons and reasons that are not epidemiologic. The way is pure like prejudice and biases and the treatments that people get. Some are economic. The question is, for those that can be corrected for, the things that can be minimized out, right? So the things that can be maximized to maximize health, maximize wellness, that we're only learning now. We're only learning in the last 10, maybe 15 years. And so you're right. The specific code to keep Dr. AI current, I don't know, but I know it's set up. I don't know the specific code by which it works, but the algorithm is that it's constantly searching. Now, the most recent stuff may not be weighted the most because there's going to have the least supporting evidence. You see what I mean? And so there's a tension there because you want the most recent current information, but you also want the most vetted information, and those two things are oftentimes at odds. And so how to dial those, how to adjust the dials to kind of like optimize that's going to be a moving target. The thing about large language models, and so to go back to one of the earlier questions, is even though it's not going to share your information with anyone without your consent, it keeps that information. And so if you've ever used ChatGPT from a year ago to now, or 2 years ago, it's the first time I used it, to now, it's 1,000 times better now than it was even 6 months ago. There is a machine learning that takes place as it learns your own personality, as it gets better, as it searches a larger set of data that's inherent with any large language model, with any AI. And this is not going to be any different. So the more you use it, the more it gets to know you. So if you go back to it, with a headache, and then 6 months from now, you come back with flu symptoms, or 9 months from now, you have a cervical radiculopathy. It'll know that, okay, it'll remember that, oh yeah, you take, Pepcid for your GERD, you take Lipitor for your hypercholesterolemia, you take metformin, and knowing that information, even though you're going back to it 6 months later, 3 months after that, it keeps track of it and it learns you. And so just like it stays current to whatever information is available, the cool thing is it's also retrospective to the information you've given it remotely. And so I don't know if that answers your question, because there's nothing that's going to fix an incomplete data set. And what you're saying is, like, you're right. As much as we want to treat everyone as equal, and it's nice to get to a point where we're kind of like race blind, the science isn't necessarily race blind. And so you're going to be limited to the data that we have available to us. But the practitioner, it'd be nice if that practitioner is not race blind, but is race agnostic. And so that's the thing about the computer, right? Like, it's completely dispassionate. You're as foreign to him as any other living creature. Does that make sense?
From your lips to God's ears. Hopefully we get there.
So, are there any questions in the chat? I'd like to hear from Dr. Lawson if he's on. Dr. Walks?
Dr. Lawson is on, if we can get him unmuted.
And any of our customers, lay people on, I'd love to hear.
Yeah, I'm just unmuted. And just wanted to know, I raised two questions. One was, of course, how do you verify the source when you do a background check? How you verify the source that the AI is using to make sure that it is indeed valid? And the other question had to do with, with now using AI for psychotherapy as well as for other kinds of medical interventions. It's interesting, it does a pretty good job. And if you look at a good psychotherapist, it's not surprising at all, because it's mostly a matter of providing space for folks to say it. The problem is they gave the example that's given is that the AI tries to please the patient, and they gave the example of a person who has an addiction and asked the AI should he use some cocaine to help smooth out his feelings, and the AI says, "Well, yeah, just a little bit at a time," something to that effect. So. Uh, while the AI is neutral in terms of values, the values do come in terms of issues around interventions that have a lot of socioeconomic implications, like drug abuse and forth. And so people are using AI for psychotherapy. They are using for addicts and others. And the question is, how do you then avoid the problem? Because the treatment itself has some implied moral implications.
It's a really awesome question. And for the scope of Hey Dre, there's no psychotherapy. So like so if you're interacting with a machine and you're basing your behavior and analyzing that's something that's a very germane subject is when you're talking about human behavior, implicit in that is a sense of right, wrong, cultural background. And so this is the biases and morals of the programmer of the machine are going to come out, right? In Hey Dre, since we're looking at something completely different, really agnostic to morals, we're really looking at you have a problem. This is the information available. And if you want to go, and so for most people, that's enough. And if you want to have the source material for each one, what happens is, let's say I have this happened recently. Let's say I have a rash. My daughter used this recently. We came back from a trip and she had a rash all over her arms and legs, and was playing around with the website, is asking the website, and it's saying, okay, based on these symptoms, she had some joint pain, this rash, and an appendicular rash. You should get these blood tests. Okay, she got these blood tests. These are the results. Okay, based on these results, it narrowed down to you have one of these three issues. Based on this, you should have another blood test. She gets these blood tests, and then it narrows it down again. It's not saying now my daughter's a 20-year-old college student. She would be less super uninterested in like the source materials of these things. But if she was so inclined, she could have said, okay, what is the source material? You could ask, there's not really a source material for saying this test for this blood test. Now, if they're interpreting, but because thankfully all her blood tests came back stone cold normal. If they were abnormal and she was said, okay, what does this abnormal blood test mean? Then it'll say, okay, so let's say this means you have an autoimmune disease. Well, how do you know I have an autoimmune disease would be the next question. That would then give you a bunch of source material. But a lot of the answers that people are asking, they're not, or the questions that people are asking, it's not something that would automatically say, it's not like a physician saying, I want to know what the appropriate ejection fraction after a left mainstream cardiac blockage is. Okay, since I'm not a cardiologist, but if my father-in-law had such a problem and I wanted to like kind of check up on the cardiologist, I may ask that question because I have a little knowledge, but not much, and I'd want to use a tool like the AI to try to amplify my knowledge so I can be a more sophisticated consumer when I talk to my father-in-law's heart surgeon or cardiologist. So that'd be an example where I'm a layperson using it, but I'm using it to get more specific information. But for a regular, and then I would use it as a tool in that regard. But for a regular user, like the example I showed with my daughter, the source material asking about, like, if I were to like, if the default setting was to present a bibliography for every question it answered, it would become, I think, more obtuse and less useful, frankly.
Let me ask you a question while our co-moderators come up with other audience questions. We're at the top of the hour. But as a physician, when that version comes out, will it take raw data like information from my 2D echocardio machine or my MRI that I have in my office and interpret it without the radiologist or without the cardiologist?
It's a great question. So the first iteration that's in the next 6 months, it'll just take the interpretation of your of the radiologist that read the cardiologist read the echo or the radiologist read the MRI. The version 2.0 that'll probably be out in 9 months, it'll take the radiologist out of the equation. Or if you have pathologic slides, it'll take the pathologist out of the equation. It'll read the slides, it'll read the MRI, it'll read the X-ray or CT scan. And then then for that to happen, we have to actually go through the FDA. It becomes a medical device because it's interpreting it's interpreting images as opposed to interpreting an interpretation, right? And so the short answer to your question, yes, that will happen. And in fact, you'll find in your own hospital-based practices 5 years from now, the radiologists are going to be few and far between. So there was a study that if you looking at CTs, mammograms, X-ray imaging of cancer detection, a doctor, a human observer, a radiologist, about 75% accurate in cancer detection. And AI looking at that now, today, 2025 data, 80% accurate. But if you use an AI with a overlooking physician, it goes up to 85%. So those numbers, that's like in 2025, and we're still in the relatively early stages. 5 years from now, you won't have, you'll have 1/10 the amount of radiologists and pathologists in a hospital. Like that's a type of medicine that will be automated before the end of the decade.
I call Dr. Walsh my personal psychiatrist. You mean I can use a machine from now on?
I think psychiatry might be a little harder because of the reasons we just said, the internal biases. Like you need to connect with your psychiatrist, whereas your AI, how do you trust the people programming it, right? And so you can get a vibe from a lifetime of interacting with people. If this is somebody that I trust, is somebody I can interact with that shares certain common, values. I think believe it or not, I think psychiatry will actually happen later than radiology, pathology, a lot of these things.
Thank you.
What do I know?
We should go with our closing comments from our co-moderators unless there's anything in the chat.
Dr. Maxey, Alice Tolbert has had her hand up for a few minutes.
Who does?
Alice Tolbert.
Oh, yes.
Yeah, AKA Coombs. I just wanted to say a couple of things. And in light of, we're going to be doing a special edition for the JNMA on perioperative outcomes. And one of the chapters is going to be on AI and postoperative outcomes. And one of the things I do want to emphasize is that we have some salient examples, actually some really stark examples of where literature meets accuracy and application. And when we don't have ongoing literature that constantly challenges the status quo, we wind up with stale information that is fed into AI. And we've all heard about the intrinsic problems with having data that does not reflect the temperament of what's at work. For instance, in triple receptor negative breast cancer for African American women, and what it took for us to discover that was a true sea change for treatment, as well as the mastectomy study that was done originally in terms of being very aggressive in treating breast, and then another study coming out dispelling that. My greatest concern now is that with all of the withdrawal NIH funding at various levels, that AI is going to be crippled far beyond anything we can comprehend, because you don't have that intellectual interrogation of data that is accepted currently to find out what are the other mitigating circumstances that result in us misinterpreting what we have right now, and is that going to change due to environmental issues? I think right now we're at a really, really difficult place because the data that we have is not constantly being interrogated. With imagery, as you know, with audio and images, generative AI does a great job. But when it comes to decision accuracy and applying current literature, it is problematic. We have historically noted that there is a rapid pace of new information, and in terms of doubling time for medical research and guidelines, that doubling time may not be doubling as fast anymore because of the research. And this is something that a lot of people have not pointed out, but we will talk about it in our article that's coming forward, that because of the current climate for research, you're going to have a different outcome. You know, the whole thing with the U.S. Task Force for Prevention, and how at one time they said don't do PSAs. And I actually fought for this at MedPAC, that the Medicare should continue to pay for PSAs because African American men had a different disease even within prostate cancer, and that not paying for it meant not screening for many. So and that has been disproven, and U.S. Task Force has retrenched on some of their recommendations. That has to happen ongoing in medicine, and we need to be cognizant of that. Without that, we're in trouble. Thank you so much.
Before he answers that question, Dr. Coombs, I want him to know your previous position in Boston and your current position in Virginia. Dr. Coombs, what was your previous position in Boston and your current position where you are now?
I was having trouble unmuting. I was past president of the Massachusetts Medical Society, publisher of the New England Journal of Medicine, and I'm past president, just immediate past president of the Medical Society of Virginia, and I chair the Department of Anesthesia at VCU.
Thank you. Dr. Nanda?
To say no, I think what you said, Dr. Coombs, is like so insightful that I look at AI as a tool, and it should never replace human decision making. It's not that level, at least not yet. And so I think things like radiology and pathology, where there's very little decision making, it's more reading and reading a picture. That's where it's so valuable. But you're right, when it comes to deciphering the really complex situation of a patient with a lot of different medical problems, you know, they have these allergies, they have this disease, they've had these prior treatments, they have this genetic backdrop. Yeah, I wouldn't trust an AI to make the decisions from the perspective of the treating physician. It's more of a tool to make the interaction for an unsophisticated medical consumer. Like in the case of me, I'm a pretty sophisticated medical consumer, but if it comes to like heart trouble, I don't know anything. And so to have that relationship with the physician is just going to make my understanding, my belief in the care provided to me or for my loved ones that much better. It's going to amplify the doctors from the perspective of the consumer. I take care of a lot of patients, right? From the very illiterate to like a lot of neurosurgeons have taken their loved ones to me to treat them for a variety of different things. And so those guys, neurosurgeons tend to be super hyper sophisticated consumers of information and medical care. And the more involved in the patient's care either the patient is or their family is, the better that patient does. And that's across anything. And so if I look at this like any other tool, it's kind of like if you look at there was a book from called Freakonomics that came out. It was like a revelatory book 25 years ago. But it looked at just one of the chapters on realtors. In general, realtors in the pre-internet age sold their house for 10% more than a non-realtor because they know the market. They have a willingness to stay on the market long until they get their price. They understand the market. Nowadays, if you do like 2 months of research on Zillow or Realtor.com, any layperson can know the market. There's no reason why there should be a arbitrage between a realtor and a regular guy selling their house. But it goes to show knowledge is power. It doesn't matter about whatever the subject. If you know how to fix your car and you take it to a mechanic, as opposed to someone who doesn't know anything about cars and takes it to a mechanic. The same thing is true when you're treating yourself or a loved one when it comes to health. And I think Dr. AI is a tool to amplify that interaction. It shouldn't replace it. And certainly it's something like very high level, like decision making. And in your case, as a previous editor for the NEJM, you're not only decision making, but you're influencing policy, you're influencing other decision makers. So that I think has to be trusted to the most, vetted physicians and thought leaders. This is not to replace that, but this is to make all of our jobs, whether from the perspective of the patient or the provider, easier, and also to amplify our efficiency so we can treat more patients more effectively.
Dr. Nanda, I certainly appreciate you giving your time today. It's been a great discussion. I really appreciate this. Would you have some closing remarks before we?
I just want to say thanks. I've really, I mean, the questions were awesome, very insightful. Shows like not only, how concerned everyone is, but how interested and invested in the topic, we're discussing. So it's really, I'm really, I'm leaving the conversation, first of all, knowing more than I started with, which is always a blessing, and really happy to be a part of it.
And thank you. Dr. Hines.
Yes, thank you very much for your time. It sounds like, Dr. AI is a very robust tool, and I am very happy that there is a physician at the head of making something like this, because sometimes we're not in the loop, and these things are developed without some of the nuance that we know, and the importance of how that language, if you present that a certain way, a patient might think that, yes, you should do that, or no, you should not do that. So I appreciate your diligence in making a tool, not a replacement.
Thank you so much, Dr. Hines. Dr. Walks.
I echo Dr. Maxey's and Dr. Hines's sentiments of gratitude for you spending the time with us. I would, this is not a question as much as it is a hope that as you all go forward, there is the ability built into the overall construct, so you can look at what Dr. AI does across the diversity of the patients and their doctors who will be using it. Are there differences in outcomes? The satisfaction survey on steroids, so to speak, so that we do have good information that folks can say, you know what, I think that thing's pretty good. So, and I'm less afraid of Skynet now than I was an hour ago. Thank you.
And thank you, Dr. Walks. Dr. Barbara Nabus-Stephens.
Thank you so much for bringing this subject to us and allowing us to poke at it with a stick. It's a kind of experience that is necessary in order to gain trust, something that we were talking about earlier. However, one of the things that I know from years in practice, and I hope is not lost as these tools such as Dr. AI are created, is that I don't care how sophisticated and technologically capable any tool or physician is, if they do not effectively communicate, it's a waste of time. So along with it making it easier for the physician, I hope physicians don't fall into the trap that being easier means that they don't have as much work to do, because their job is still there to make sure that the patient understands and is a partner in whatever the therapeutic journey is.
Well, thank you so much. And in closing, I want to say two things. One, I hope that Dr. AI will allow the Black Health Trust to be advisors or consultants as they bring this to market. We'd love to play a part in the thought process if that's possible. And number two, our program next week, I'm really excited about as well. We're going to have Dr. Lawson, Dr. Napoleon Higgins, Dr. Georges Benjamin, and Dr. Walks. And the topic is current public health policy a form of eugenics? And you can look up that word eugenics if you want. But we think that there may be a lot in there that may be detrimental to people of color. So welcome back next Sunday, the 8th. And Dr. Nanda and company, thank you again for bringing us Dr. AI.
Thanks so much.
And thank you, Simon.